A very warm welcome and thank you for joining us for this webinar on harnessing social protection to improve HIV outcomes in vulnerable children and adolescents. My name is Luann Hatani. I am the Executive Director of Pediatric Adolescent Treatment Africa, PATA, and I also serve as co-chair for the Coalition for Children Affected by AIDS. The Coalition is an independent group of thought leaders from donor, UN, NGO, and academic communities. We advocate globally for the rights of excluded children and adolescents affected by HIV and AIDS. The Coalition is delighted to be co-hosting this webinar with the Interagency Task Team on HIV-sensitive social protection, the OVC Task Force, and ViiV Healthcare Positive Action. We thank our co-sponsors most sincerely for their involvement and all their support. Also, first and foremost, we must acknowledge the fantastic organizations who we will be hearing from a little later. It is their incredible work that has brought us all here today. These organizations are all winners of the Reaching All Children Positive Action Challenge. This challenge, co-sponsored by the Coalition and ViiV Healthcare, sought to identify proven examples of social protection being harnessed to improve HIV outcomes in vulnerable children and adolescents. All of the 8 winners were supported to document their work so that others could learn from it. We now have a fantastic body of evidence showcasing what works. This evidence, as you all know, could not have come at a better time. COVID-19 has exacerbated the social and economic barriers that prevent children and adolescents from accessing healthcare. We are all looking for practical ways to improve and provide holistic care and support, including UNAIDS and the Global Fund, who are both developing their new strategies with the aim of reaching those left behind. These innovations show us all what is possible and what can be done. Before we hear from them, we are really honored as a coalition to have opening remarks from an esteemed panel who will also examine the challenges from both a global policy and programmatic perspective. We're also very keen to hear from all of you and invite all of our attendees, please, throughout the webinar to put your questions, comments, etc. in the Q&A or in the chat box. And if they're directed at a particular speaker, to please note that as well. Finally, a huge thank you to Kathy Ferrier of ViiV Healthcare for giving her reflections at the end of this webinar and for ViiV's ongoing support to the Coalition to Reach All Children. Thank you so much.
Good afternoon and good morning. I want to thank the folks from the Interagency Task Team on HIV-sensitive social protection at UNAIDS, ViiV, the OVC Task Force, the Coalition for Children Affected by AIDS, and the many other partners who are on the front lines every day harnessing social protection to improve the lives of children and families affected by HIV. So I'm here to talk about the President's Emergency Plan for AIDS Relief. And as of the end of our fiscal year this past September, PEPFAR had supported more than 6.7 million orphans and vulnerable children and their families to mitigate the physical, emotional, and economic impact of HIV/AIDS. So PEPFAR's OVC program specifically addresses what we call the social determinants of health, those underlying factors such as stigma, poverty, violence that are barriers to successful prevention and treatment. As such, it exemplifies a commitment to harnessing social protection, and it also it encapsulates an understanding that for our most vulnerable population, it often takes more than medicine, as critical as drugs may be, to achieve viral suppression. Our OVC program supports this continuum of HIV prevention, treatment, and care, really by leveraging a wide network of community-based organizations who regularly serve children and families where they live, providing much-needed socioeconomic assistance. And I think what's important to share with you is that what we've learned in terms of being able to harness social protection for treatment outcomes is that we had to close the gap that often exists between health facilities and households. And we do this by using case management as a platform and by having case managers serve as essential members of multidisciplinary HIV care teams. We also close this gap by establishing agreements or memorandum of understanding between the health facilities and the area social service organizations, and by promoting regular case conferencing. So OVC case managers, who are largely employed by social service and community-based organizations, are actually placed on site in the health facilities, and that way they're able to work closely with the medical providers. And I think it's important that the tool that they often use is a case plan. So for each child in their family, they have a case plan that outlines goals that are specific to HIV. Some are prevention goals, such as ensuring that all family members have been tested or index testing. But there are also goals related to their greater well-being. So in the PEPFAR program, we have 4 core domains that we call healthy, safe, schooled, and stable. And for example, stability refers to household economic stability as well as stability within the child's care situation. And by doing that, we're definitely joining both that clinical goal as well as the related social protection goal. So I think what's important to know is that while this work in some ways is still new, we have seen encouraging signs that this is working. For example, one of the things we've done is compared program data for populations of children living with HIV who are both in the PEPFAR OVC program as well as PEPFAR treatment programs. And we've compared them with those who are only in the treatment programs. And we do see a positive trend in terms of outcomes such as viral load suppression and viral load coverage for those who are enrolled in OVC in some of our countries. I think it's also important to point out that OVC programs have also helped in other ways in terms of treatment goals. So for example, during COVID, with all of the lockdowns, the OVC programs have really played a role in ensuring that children have access to multi-month dispensing programs, whether they're 3 months or usually for children, they're about 3 months. So I think that has been critically important as well. We're really happy to see that a number of our PEPFAR funded partners are on the agenda today. And I and others from PEPFAR, we look forward to hearing from you firsthand how you're using social protection to improve children's lives. So thank you so much for having me here today.
Hello, I'm Suki Beavers, and I'm the new Director of the Gender Equality, Human Rights, and Community Engagement Department at UNAIDS. Thank you to the meeting co-organizers, distinguished speakers, and participants. I'm really pleased to be with you and to share this session with the speakers from the Government of Germany and PEPFAR. Today, I want to share with you 3 headline messages. First, the AIDS response is failing children, adolescents, and particularly adolescent girls and young women. Second, the evidence of the positive impacts of social protection on HIV and non-HIV related well-being of children, adolescents, and women, including adolescent girls and young women, is strong and compelling. And third, to meet the needs of vulnerable children, adolescent girls, and young women, we need quantum leaps. Social protection as part of a larger effective response can help make these quantum leaps. I now point to some of the sobering numbers and realities that we all know. HIV infections in infants have been reduced by over 60% since 2000, so that today, most HIV positive mothers can and are having children who are born free of HIV. However, the world missed the target of attaining fewer than 2,000 new child infections by 2020. And we know that children born to mothers with HIV who are HIV exposed but uninfected may experience twice the rate of illness and death than infants who are not HIV exposed. And really tragically, 6,000 adolescent girls and young women aged 15 to 24 years in Eastern and Southern Africa become newly infected with HIV every week. This situation is completely unacceptable and it is preventable. We have to commit to implementing what we know works, and social protection works. It empowers children, adolescents, including adolescent girls and young women, to flourish in the lives they choose. It also increases retention in HIV care for those living with HIV. Evidence shows that social protection's HIV prevention impacts range from 25 to 60% in Eastern and Southern Africa. The COVID-19 pandemic response shows us that what is often seen as impossible is in fact possible when the urgency of the situation is met with high-level political commitments, resource allocations, and the prioritization of the right interventions. Social protection can help us make quantum leaps in HIV treatment, prevention, and non-discrimination. But national social protection systems, which are so important, are unlikely to effectively include orphans and vulnerable children, women and girls, people living with HIV, key populations, as well as people with disabilities, the very people who require social protection most. We need to support specific interventions, including those that we know only communities can deliver effectively. Communities are often best placed to identify who's vulnerable and left behind, and to challenge and transform the legal and social and economic barriers that limit access to social protection services. Winnie Byanyima, the UNAIDS Executive Director, and the entire senior leadership team, and I enthusiastically look forward to further engagement on social protection, given the prominent placement of it in the new global UNAIDS strategy. I thank you.
Good afternoon to you all. Let me start with Rachel. Like 72,000 other adolescents in Zimbabwe, she is living with HIV. Fortunately, she has the life-changing medicines, ARVs, which will enable her to grow up into adulthood if she takes them every day for life. If only it were so straightforward, though. Whether Rachel will take these tablets and whether they are able to do their job depends on numerous factors, often complex, challenging, and multifaceted issues. Rachel's daily life, her reality, is one of stigma, grief, loss, neglect, lack of information, confusion, isolation, fear, uncertainty, anger, loneliness, and suicidal ideation. If children and adolescents living with HIV are to survive and thrive, they need services which address these realities, ensuring that psychosocial support is fully integrated within their clinical care. Zvandiri does just this. Zvandiri, meaning as I am in Shona, focuses on the realities of young people's lives, recognizing and responding to the barriers which young people face in accessing HIV testing and treatment, or the challenges they have adhering to their ARVs or remaining engaged in care, as well as the mental health and protection risks which are so alarmingly prevalent in this population of young people. And we do this through the most awesome cadre of trained, mentored young people living with HIV. We call them CATS, or Community Adolescent Treatment Supporters. They are based in the clinic, not as a patient, but as a critical, respected, valued member of the healthcare team, strengthening the provision of child and adolescent HIV services in the clinic, but also extending beyond the clinic into the communities through home visits, support groups, and mobile health. They manage their caseloads of children, adolescents, and young people living with HIV, providing them with information, counselling, monitoring, and support, so that their young clients have the knowledge, skills, and confidence required to remain engaged in care, to take their medication, and to make safe, healthy, informed decisions about their health and lives. They work with caregivers and families, strengthening the support and home environment for young people living with HIV. They aim to ensure that their clients do not feel alone or unable to cope, but that there is someone else who understands their experiences, their worries, their challenges, and ensures they are linked to the services they need. We started with 10 CATs. Today in Zimbabwe, there are over 1,400 CATs, supporting 56,000 children, adolescents, and young people. In partnership with WHO, regional governments, funding, and implementing partners, this Zvandiri model has now been adopted or adapted in 8 other countries in the region, with 400 cats supporting 1,500 young people living with HIV. Our program data and research studies we've conducted with research partners have found that young people engaged in Zvandiri have improved uptake of HIV testing services, improved retention, adherence, viral suppression, and improved mental health. ARVs were indeed a game changer, but this model has been found to treat the loneliness and fear that so often comes with HIV. And this not only helps children and adolescents to take their life-saving drugs, but also changes the quality of their lives. The Positive Action Challenge has given us the most amazing opportunity to document this Zvandiri approach to improving outcomes for children and adolescents living with HIV. But we wanted to give young people the opportunity themselves to document it through their own words, pictures, photos, drawings. So we engaged 9 young people from across Zimbabwe, each with their own stories and challenging circumstances, and guided them through a digital storytelling process. The result is a collection of 9 unique films, often distressing, but ultimately stories of strength, resilience, and transformation, with young people supporting one another at the forefront of the HIV response. I will close by handing over to Nyasha, the author and producer of one of these films. Through her story, she clearly demonstrates that what children and adolescents need is so much more than just the medicine. Thank you so much.
My name is Nyasha and I'm 18 years old. I've had a lot of things that happened in my life. I never knew my father. He died when I was very little. And when I was in grade 3, my mother passed away. And I had to go and stay with my aunt, her husband, and their children. I always felt that they never wanted me around. My aunt and my husband sometimes say bad things about my mother, saying that she's the one who brought HIV into our family and it was her fault that my father died. I don't know what's true, but I loved my mother, and it makes me angry when they say these things. My life changed a couple of years ago when I started dating Tendai. He was kind and I thought he really cared about me. He made me feel like I mattered the most. After dating for almost a year, I decided to disclose my status to him. At first he said he loved me and it was okay. But then he went silent. He stopped messaging me and he wouldn't answer my calls. His friends started to ignore me. It wasn't long before I saw him with a new girl, someone who used to be a friend of mine. Then to make things worse, he told others about my status and that they shouldn't date me. I felt so betrayed and angry, like everything was taken away from me. I had trusted him. I got really depressed. I felt so ashamed of who I am, worthless, and like no one would ever want me. All I really wanted is to get married to someone who loves me and to have babies, but that probably won't even happen. I stopped caring about anything. It seemed like there was no reason to live. I stopped taking my pills because I didn't see the point in staying healthy and alive. Sometimes I thought about taking the whole bottle of my pills so that I'll end my life sooner. I lost a lot of weight. I couldn't sleep and stopped getting together with girls who I thought were my friends, but now were gossiping about me. I hated going to school where I had to face people, and a lot of days I just stayed at home. Things were bad at home too. My aunt was mad that I wasn't doing anything and yelled at me a lot. Patients and kids from the clinic came to visit me at home because I had missed a clinic appointment. At first I told her I didn't want to talk with her, but she kept trying. She kept messaging and stopped by another time. I finally opened up to her about what had happened. She also had a boyfriend who dumped her and could really understand. When I finally told her I had stopped taking my tablets and that I wanted to die, she said she needed to talk with the supervisor, the counselor at the clinic, who I know. After they talked, they referred me to the mental health nurse at the district hospital. I didn't want to talk with someone new and I didn't see how it would help, but patients insisted and went with me. The nurse was very nice and I liked talking with her. It made me feel better. Also, patients kept visiting me at home, talking with me, encouraging me. She got me to see that I hadn't lost anything and I still have a lot to live for. I started taking my pills again. I take them every day now. I think that if I get a chance, I'd like to become a kid too. I'd like to help others like the way patients help me.
Thank you all and welcome to our sharing about the Cheer Up program. It began in 2013 in Kiambu County of Kenya, Central Region of Kenya. Cheer Up is a community-based organization that seeks to improve the quality of life of marginalized, orphans, and vulnerable children and their caregivers. I want to talk about an intervention, household economic interventions that combines HIV support for our OVC children to maximize outcomes and benefits on HIV care and treatment. The goal of the project is to address both HIV and chronic poverty facing the OVC and their caregivers, while addressing barriers to HIV care and treatment. We aim at strengthening the resilience and earning capacity of caregivers in different ways, adapted to the needs and capacities of each household. And some of the interventions for the households that we are focused on is providing high-grade dairy cows, merino sheep, business grants, linkages to savings and loaning schemes, while for the older OVC, we retain them in vocational technical skills such as tailoring, engineering, mechanical engineering, and other high-value market-oriented courses. One other thing about the program is that each household receive regular training on how to maximize their businesses. Also, the households receive regular support from CHVs who visit them regularly to ensure that the outcomes and the achievements around the business they are holding translate into improved outcomes on HIV prevention, care, and treatment. All caregivers receive joint caregiver support, which is the source of more knowledge, learning, improvement, and adaptation to the care and treatment. I also want to share the results of our intervention. The program supports 9,000 OVC, 100 of whom 188 are living with HIV. Throughout the program intervention, we attained 100% adherence rate and 92% viral load suppression among them. One other result is that the number of HIV positive children who receive care doubled because of the internal leveraging on household economic strengthening. And those who tested for positive increased from 28% to 96%. And the number of enrollment into the program increased from 40% to 90% who have been retained in the program. We have also doubled the number of community health volunteers because of household economic strengthening, which targets the households where we have the OVC as well as the CHVs. And we have had a higher retention rate for the CHVs in the program. That has also translated into improved outcomes in nutrition, protection, psychosocial support, as well as education, since the households are able to meet their basic needs from household economic strengthening. Lastly, I just want to comment briefly about what has made this project so effective. Household economic strengthening carefully targets OVC living in chronic poverty and who are often left behind, and their caregivers cannot fit well or meet the requirements for microcredit institutions. So household economic strengthening comes in to make sure they are able to engage in gainful business. Household economic strengthening contextualizes and is responsive to local business opportunities. That means a household will be able to fit in the local business chains, value chains, and maximize profits and take care of the children. The household economic strengthening intervention is a truly pro-poor because it has no debts. There's no repayment on the investment that we provide to the household, and it suits the poor families, and it suits poor families that cannot afford credit schemes elsewhere. Household economic strengthening is scalable, affordable, and replicable, and it combines HIV and household economic strengthening that brings substantive changes to the household while reducing poverty and eliminating barriers to HIV prevention, care, and treatment. Thank you very much.
Good morning, good afternoon, good evening, ladies and gentlemen. I am Dr. Winnie Nambazira, the Executive Director for Brewin Foundation, a local NGO in Uganda, supporting children and adolescents who are infected and affected by HIV/AIDS. And we implemented a social protection intervention supported by ViiV Healthcare and Coalition of Children Affected by HIV/AIDS. And we did this through an economic adherence support clubs. And these are peer-led clubs for caregivers, for non-suppressed children and adolescents, in order to address challenges concerned with adherence to ART, as well as retention in care for children infected with HIV. This called for supporting the social and economic aspects of the lives of the children and their families. Brewin Foundation partnered with 2 health facilities during the project in Mityana district, which is in central Uganda, rural Uganda. Children with non-suppressed viral load were identified by health workers, and their caregivers were invited to join the groups stroke clubs. 23 caregivers joined the clubs with a total of 29 children and young adolescents. Initial trainings of caregivers were conducted, including financial literacy, saving schemes, communicating with children in terms of disclosure, stigma, and adherence, and income-generating activities such as soap making, piggery, goat rearing, to be able to generate an income for the households and therefore able to meet their needs. In the pictures as seen here, we can see some of the trainings that took place. In one picture, we can see a financial literacy training for the women and stroke caregivers, because most of them are basically women. And then we can also see on the other side soap making training still for the women. Some of them had come with their children actually. So what do the clubs actually consist of, and what activities were they actually doing? The clubs consisted of basically 10 to 20 caregivers of the children and young adolescents living with HIV. Clubs were affiliated to the health center where the children obtained care from. However, the clubs were not actually meeting at the health facility. Rather, they met in the community so that the caregivers would be comfortable, it would be accessible to them, and they would be able to share openly issues concerning their children. Club leadership included a chairperson, a treasurer, and a secretary to be able to run the club activities. And activities included peer-to-peer support, club saving, as well as economic activities such as soap making. Some of them were group activities, some of them were individual. And ultimately, at the end of the day, they needed to save so that they can have something to fall back on and be able to meet their basic needs, be able to meet the transport costs that they incurred while seeking health care for their children. And we can see in here in the picture, we can still see the club members for the 2 groups, because there were basically 2 health facilities. And here we also see in some of the pictures talking about our peer-to-peer support. In one picture, we can see the very women actually supporting each other. And then in the other picture, we can see one of the caregivers actually having further professional psychosocial support for myself, actually. So what outcomes did we actually have after the clubs being formed? We had viral suppression for children. In just 6 months, we were able to have 75% viral load suppression for our children. And the adolescents were actually at 86%. Then we had improved appointment keeping and therefore retention in care. By the end of 6 months, we were not having any child missing an appointment. And those who actually missed were able to come at least within 1 day from their appointment date. Then we have also seen results of improved nutrition outlook for the children and also for the caregivers at large. Then we have also had improved well-being of the caregivers as well as the children. And this has basically, we assess this through a tool that we've developed as an organization to assess their psychosocial well-being. So, and for those caregivers who had children who are suppressed, we can see they received rewards to encourage the other caregivers to continue doing a good job. So they received school bags and then also T-shirts. And that's all that we had for you, really, in Brain Foundation. Thank you. Mwebalenyo.
This project, which I'm going to discuss about, is mobilizing HIV-positive mothers for PMTC service in Oromia of Ethiopia. It is an innovative project because in Ethiopia, studies show that transmission of HIV from mother to child is more than 9%. We do 4 major activities in the project. One is referral linkage, where our HIV-positive volunteers go village to village and look for pregnant women to attend to conduct HIV testing. When they found HIV positive, we put them on PMCT services so that they can give birth to HIV-free babies. The other one is we do income generating scheme. We train them, form them in cooperative, and give them startup capital so that they can run their small business in a cooperative form. The other one is providing emergency nutrition support for needy lactating mothers. And the other one is awareness creation for reproductive age women regarding prevalence and HIV infections. So with this project, we achieved remarkable results, especially with the prevention of HIV, transmission of HIV from mother to child. We achieved like 99% of the set project objectives, where more than 560 kids are born free from HIV AIDS from HIV positive mothers. With the nutritional support, we also achieved more than what we said, because we mobilized local resources to address such gaps emanating from addressing the problem of needy lactating mothers. And with income generation scheme, we also achieved remarkable result, but because of the outbreak of COVID pandemic, some of the activities were not went the way it was planned. And regarding awareness creation activities, we achieved the project set target, which is 100%. And this is the achievement of the project so far.
My name is Catherine Roberts. I'm a postgraduate researcher based at University College London, and I'm part of the Child Community Care Study team. The Child Community Care Study, set up by Stellenbosch University and University College London, is a cohort study of children and their caregivers accessing community-based organisations within South Africa and Malawi. In this instance, we have used cross-sectional data from just under 800 children and adolescents affected by HIV, aged 5 to 15 years of age, to explore the impacts of social protection. We know that children affected by HIV may be impacted by economic hardship and developmental challenges. And in these instances, social protection may be of benefit. Our analysis examined whether combinations of cash grant receipts and food security status had an impact on cognitive and educational outcomes. These social protection measures were already in place within communities. So this isn't an intervention per se, but an examination of existing provision already in place at a community level. We examined 3 groups within our analyses. So those that didn't receive any social protection, those that received either a cash grant to their household or reported being food secure, and those that received both social protection measures in combination. So what did we find? Compared to no social protection, those that received either measure of social protection, so being in a household in receipt of a cash grant or being food secure, were found to be associated with greater odds of being in the correct class for age, higher scores of non-verbal cognition, and higher working memory scores. Being in receipt of both social protection measures in combination were found to be associated with reduced educational risk scores, improved odds of being in the correct class for age, regular school attendance, higher scores of non-verbal cognition, higher working memory scores, and the ability to learn new things more easily. So combined social protection is not only showing an enhanced impact that we're seeing for a single social protection intervention, but is having a broader reach of improved outcomes for children and adolescents affected by HIV. There's an ongoing question from governments and stakeholders regarding which single social protection intervention should be funded or provided. And as these data demonstrate, social protection is having an impact on fundamental outcomes for children and adolescents, which may have lifelong consequences. Here we're looking at child cognitive development, which may have implications across the life course. And as these data show, and in doing so, they're building on a bank of existing evidence, is that rather than providing a single social protection intervention, if you want to have a broader reach, give a basket of provision. We also don't necessarily need to be searching for a magic bullet here. The social protection measures within our study were cash grant receipt and basic food requirements. Good, solid, data-driven provision that was already in place at a community level. And we have seen time and time again that this provision can be delivered at scale. So in this instance, the options are seemingly already there. It's just about ensuring that these children and their caregivers are able to access them to ensure that they are no longer left behind and that they are given every opportunity to reach their full potential. Thanks.
My name is Roger Simiu. I work with the Elizabeth Glaser Pediatric AIDS Foundation in Kenya, where we are seeking to eliminate global pediatric HIV. ECPAF is a global leader in elimination of pediatric HIV, working in 17 countries globally and in 15,000 sites, all in different communities. Today I'm here to talk about the bread of life, which was an intervention that we implemented in Turkana in Kenya. And this is generally a nomadic population in the northern Kenya. And we did this initially we did this in one of the facilities that is Loaringak Health Facility. And in this facility, we noticed that the children and their mothers were experiencing poor outcomes, which were related to poor appointment keeping, also related to poor viral suppression, and generally we're seeing that the mother-to-child transmissions were getting higher in this facility. When we sat down with the mothers, they gave us feedback on one thing, that their biggest challenge is lack of food and also lack of income to be able to come to the facilities. These women notably had to travel more than 30-40 kilometers, basically walking, to be able to come to the appointment, because in Turkana, facilities are more like between 70 to 100 kilometers apart. So what we did was we did a combination of three things, that is combined HIV treatment literacy, that is just increasing the knowledge of the women about HIV treatment and what they need to do with their children. And then we also focused on empowering the women, empowering them so that they would be able to have some capacity to manage, to run self-help groups and also run some self-entrepreneurship activities. In addition to that, we focused also on empowering them economically, that is through skills development, where they chose baking bread. And this was a basic skill which would enable them to avail bread on the table and also sell some bread to make household income. Through this, they were able to raise money that was sufficient to help them come to their clinic regularly, and also get money that was enough to help them pay school fees for their children. So school attendance for their children also increased, and basically manage their day-to-day expenses in this hardship area. Bread turned out to be the best intervention because this area is known for limited rainfall, so agriculture was not viable, livestock keeping was not viable, so it turned out that bread was the most viable project. Over the time, we saw that household income increased from almost near zero to close to 5,000 shillings a week. And that was very, very good income per household, where they're able to afford basic life items. And also, the appointment keeping retention in this facility increased. We saw close to, basically the appointment keeping went from 50% to close to above 90%, and even those ones who were able to miss appointment could be able to report back in the facility their reasons for missed appointment. This went ahead and even got up into the men, and the men also were influenced, and the overall seeking enrollment in this facility improved from 133 clients to over 200 clients. Because now identification was easy, it went ahead even into reducing stigma in these facilities. So out of this, we do realize that it is important to go beyond the basic clinical and basically prescribed interventions within the guidelines, and go into the patient-centered needs. Meeting the patient needs, basically somebody would almost think as patient needs as the fourth 90, where you focus on what are the real barriers that these patients are facing. We did scale up this intervention from this one facility to 15 facilities, and clients overall we saw better outcomes for children. One other thing I would like to say is that throughout between 2017 to 2019, when this project was winding the pilot phase, the mother-to-child transmissions had reduced significantly. This project is scalable, and it's good to include this as one of livelihood support as one of the key interventions in patient-centered approaches, and more so communities have great solutions to their issues. Thank you.
Good morning, good afternoon, good evening, depending on where you're watching this webinar. My name is Josiah Kiarie, and I work for the Catholic Diocese of Ngong. We are a faith-based organization working in rural Kenya, supporting communities to access healthcare, education, decent livelihoods, water and sanitation, and prevention of violence and conflict. The challenges facing children in our community, especially those affected by HIV and AIDS, are lack of good nutrition, illiteracy, low incomes in the family, lack of information about HIV and AIDS, sexual and gender-based violence. The children also live far from the health facilities, which makes it expensive to go to access the health services. We have served 5,262 children, and out of these, 787 are children and adolescents living with HIV. From 2018 to 2020, we have seen viral suppression rates increasing from 63% in 2018 to 84% in 2020. So how did we achieve these results? Participation is very critical. We involved the community, we involved the child, we involved the household, and we addressed system challenges that prevent children from accessing HIV services. Sometimes it's very simple. It could be buying a clock with an alarm for a child so that they get to know the correct time to take the medication. It could also be for another family buying them a flock of chicken that will provide for them eggs to improve their nutrition, as well as sell the surplus to get incomes so that they are able to afford bus fare and pay for the children's transport to the health facility. So our approach has several steps, and one of them is involving the community. We invite members of the community in social places, churches, community grounds, and they come together to identify the challenges affecting the community and propose solutions based on the available resources. We also involve the household in identifying the gaps that prevent access to healthcare. The other step would be sitting down with the family and a community volunteer to develop a care plan for each and every child to help them address the gaps to their healthcare and well-being. After this, the community health volunteer will be making monthly visits to the household to be able to monitor their progress and offer referral and linkages services to other services available in that community. Over a period of time, this household will be graduated out of the project and therefore give rooms for others to benefit from the same program. This is our social protection programming approach. It avoids a one-size-fits-all programming and mentality. The other thing that we do is policy advocacy and support government and institutions to implement the policies that are available. This helps children to access broader services where these services are provided for by policy. An example of this is cash transfer programs. We assist the Department of Children's Services through the community volunteers to identify the most vulnerable children, and this has improved targeting of the vulnerable families. So what have we seen as the results? We have served over 5,000 children with social protection services. 80% of these families report improved nutritional status. 93% of the children who are of school-going age are retained in school. And the HIV prevalence rate among the children in our program is 0.5% compared to 4.9% in the general population. So our call to policymakers and funders is to support social protection services as part of the care package for children and adolescents living with HIV. We are saying that comprehensive care for children and adolescents living with HIV has to be truly comprehensive. Thank you.
Hi everyone, and thanks for the opportunity to present today. My name is Dr. Rebecca Hope, and I'm the Executive Director of YLabs and a co-investigator on the YBank Social Protection Project. YLabs applies behavioral science, human-centered design, and adolescent neurodevelopment to co-design solutions with youth. We believe that there should be no design for youth without youth, and I thank all of the young people who contributed to the design of this intervention. Whilst ART has dramatically improved survival for all people living with HIV, mortality continues to rise among adolescents, driven by the survivors of the perinatal epidemic and in stark contrast to all other age groups. Adherence is a consistent global challenge. It is as yet an unsolved problem, and it is killing young people at the peak of their potential. The YBank project was a response to this need to support young people with their medication adherence to improve their long-term health and survival. A human-centered design approach was employed to engage adolescents living with HIV in the design of the YBank program. I'll talk today about the design and pilot phases of the project, which engaged adolescents, parents and caregivers, and healthcare providers in Rwanda to test a social protection program to support young people's adherence and engagement with HIV care. Through an iterative co-design project, we sought to understand adolescents' priorities and key barriers to adherence. We heard that young people's most pressing priority was their economic future. They were worried about school fees, supporting their families, and often lacked money to get to the clinic. And building on what we know about adolescent neurodevelopment, we incorporated peer influence and rewards as design elements. Adolescents typically struggle with future planning, and we sought to design an intervention that could support them to think about investing in their health as an investment in their economic future. The intervention consisted of two components: financial incentives and peer-led life skills training. Short-term incentives were delivered via mobile money, and long-term nest egg was deposited into a long-term savings account with a national bank. Adolescents received a SIM card on enrollment and were eligible to receive cash transfers for coming to clinic and having a suppressed viral load at the end of the study. The savings card in the picture helped them track their funds alongside their viral load. Their life skills trainings focused on financial literacy with workshops on money management, entrepreneurship, and saving skills. Cash amounts were capped at 8,000 Rwandan francs, which was the equivalent of around $10 at that time. 72 adolescents were recruited through random sampling from an urban clinic and a rural clinic. They ranged in age from 12 to 19 with a median age of 15, and the majority had acquired HIV perinatally. Importantly, more than half of our study population had experienced the loss of at least one parent, and 13 were double orphans. We had no loss to follow-up, and we had near-perfect attendance for clinic visits and life skills training sessions, which were optional. It's first important to say that the goal of this pilot was to investigate the feasibility and acceptability of the YBank program. It was not powered to look at effectiveness, though I will note that the results show some potential to increase the percentage of adolescents who were virologically suppressed. This was not statistically significant, and we would need to examine this over a longer time frame with a larger sample size. However, it was overwhelmingly acceptable and potentially impactful based on the qualitative findings from adolescents, caregivers, and healthcare providers. Adolescents described feeling encouraged, appreciated, and motivated by the incentives in the program. They said that it gave them something to look forward to at each appointment, counteracting the dread that they often felt when they thought about their HIV infection and going to the clinic, and this quote demonstrates that well. Similarly, caregivers were positive about YBank, particularly around the changes and transformations in health behaviour and mood. Many felt that they were more able to talk to their children about their adherence due to the programme, which is captured here in this quote. Often adolescents are excluded from social protection programs due to a fear of them using funds inappropriately, and like in other studies, YBank found no evidence of risky spending. The healthcare workers we also interviewed reported no additional burden from the program and were positive about its impact on young people. And in summary, all of the 54 participants we interviewed at Endline found the intervention highly acceptable, with emotional and financial benefits associated with the incentives. Feeling rewarded combined with planning for the future was a key theme expressed by adolescents who took part. The results of this study lay critical groundwork for evaluating and scaling social protection programs of this kind, and as a next step we'll be exploring a cluster randomized controlled trial in both urban and rural areas to explore these following points further. So why is social protection important? I think there's 3 key takeaways I'd like to share. One, I think these programs have potential to drive equity for the most vulnerable youth. Sure, we've made ART far more acceptable, that's true, but it's not often getting to the most vulnerable. Young people living in poverty have much more pressing concerns and often lack the emotional support to deal with the psychological burden of growing up with HIV, and this program sought to address both of those needs. 2, I think starting with trust is so critical. Moving from the assumption that young people can't be trusted and will take risks with these funds to that young people need to be supported and they are the experts on their own lives. We took a lot of time to design this very carefully with young people to ensure that the incentive was motivating but not coercive, and testing and prototyping different delivery mechanisms and amounts was very helpful. Finally, and most importantly, I think building on what young people want, not what adults think they need. Widen created an environment where young people were set up to succeed. All young people used the funds really responsibly, and attendance to the optional trainings on financial literacy was near perfect. They were really excited about this program, and I think demonstrated to our team that when we focus on what young people really dream of and are prioritizing instead of what we think they should have in a program, we can successfully engage them with care. Finally, I'd like to thank all of the participants who took part in this program and contributed their ideas and input, and also all of the co-investigators globally that worked on this project. Thank you.
Karina Charkey, and I manage the Coalition for Children Affected by AIDS. We are very fortunate to have almost all of our presenters here with us for the live discussion. And we're also joined by 3 eminent commentators: David Chipanta of UNAIDS, Alison Oman-Lowy of the World Food Program, who is representing the IATT on HIV-sensitive social protection, and Janet Barry of the Botswana Initiative of World Education, who's representing the OVC Task Force. A warm welcome to them and to everyone joining us. We now have around 30 minutes for a live discussion, and I invite you to post your questions and comments in the chat box. And I thank the many of you who submitted some to me in advance. I'd like you all to note that this discussion is being recorded and to ask our panel to be concise in their answers. Before we start, I'd like to clarify something that was raised in the chat box, which is that we have used throughout this webinar and throughout the Reaching All Children Positive Action Challenge, the definition of social protection used by UNAIDS and other co-authors of the joint statement. And this definition refers to social protection in a comprehensive way, encompassing a broad range of social and economic supports to enable vulnerable people to overcome barriers to health services. So this could be a range of interventions from cash transfers right up to positive parenting and beyond. Okay, I'd like to start by inviting Alison Oman-Lowy of the World Food Program to comment on the use of social protection and the World Food Program's experience on behalf of the IATT on HIV-sensitive social protection.
Thank you so much, Karina, and thank you, everybody. It's really nice to be here. Very inspiring to get to listen to the different co-panelists and those presentations. It's very easy in my job to get removed from the work that's going on in the field, and to see something like these 8 different examples, really, I really appreciated it. So I've been thinking a little bit about my intervention, and I guess the thing that I wanted to say really, I'm taking a lot from you, Josiah, and from what you talked about, because I think that the first thing is this idea that we think of social protection as so complicated. Oh, how to ensure that children and adolescents benefit from social protection is enough to make people pause in their tracks, thinking that it's a highly complicated issue, when in fact it really isn't. When you think about what social protection is fundamentally a compact between a government and its people. It's fundamentally rights-based in the sense that everybody has a right to those government interventions and everyone has a right to live and exercise within that country to the full extent of their rights. And then I think that it also fundamentally talks about this idea of the need for something that's systematic, that's deliberate, that's predictable, that is accessible, and that is sufficient. And that really is where, for me, the social protection issue comes to a forefront. I think about how much we see that people living with HIV have to endure these intersecting inequalities. They're not just living with a disease burden, but they're living with often the poverty, often the stigma, and all of these other inequalities that make up a burden that is very, very difficult to overcome. And that's where I want to steal the second thing from you, Josiah, and that's this idea of comprehensiveness. We talk a lot about comprehensiveness, and when we in WFP think about social protection, it's this ability to think comprehensively about what an individual needs. Fundamentally, as the World Food Program, we're very dominated by our thinking about SDG 2, thinking about ending all forms of hunger, ending all forms of malnutrition, ending food insecurity. But we also recognize that how can you exercise your right to food? How can you be free of hunger, free of malnutrition, if you don't also think about your SDG 1, poverty, SDG 3, which is looking at health, education, equality, all of the other ones. So I think that for me, this comprehensiveness of a social protection scheme. So for WFP, over the years, we have gotten more and more involved in supporting governments with social protection. So what does that mean? We really have three primary entry points. Either we are giving technical support and advice to a government who already has a social protection system running that maybe says, how could we better include people living with HIV? How could we better think about social protection that's nutrition sensitive? The second is helping governments actually set up their models, setting up targeting frames, setting up the design of a social protection program that could include looking at the transfer values and what we in HIV talk a lot about as cash plus. And then our third entry point is really just doing some direct implementation ourselves. There are still places in the world in that highly fragile, often conflict-torn areas where WFP sets up almost a shadow alignment of a social protection system that's shadowing what a government would eventually put into place. So this is a long-winded way of saying that for us, we really believe that fundamentally social protection is a way to reach a lot more people. And on the one hand, you can talk about social protection, which allows us to simply remove the barriers in an existing program so that people living with HIV, and particularly children and adolescents, benefit from a social protection safety net project, for example, or at the far end of the continuum, which is one that is directly designed for those very people and has all of the comprehensive elements that allow people to not just live with HIV, but to thrive. We've seen over the years, as the test and treat regime has, thank God, saved so many lives, people are living longer. But what is the quality of life if you're living with HIV and you're impoverished and you can't afford a diet, you can't afford the basic nutrition needs that you have? And so I think that for the WFP work, and then also very much what the IATT is focusing on, is one, ensuring that people living with HIV have access to these social protection programs, but then making sure that those programs are comprehensive. All of the things that you all raised in your panels, I mean, transportation, skills, giving food and nutrition support, something as basic as a $2 transfer in addition to a test and treat regimen can make all the difference. And I think fundamentally, one of the things that we're giving is we're giving care. We don't usually think about it like that, but adding this element of care, the element of counseling, especially for adolescents and their families, this idea of creating a safe environment where people can live and thrive. These are all the things that we believe fundamentally in.
Great. I'd now like to invite David Chapanta from UNAIDS to comment on how can the UNAIDS and UN normative guidance more broadly help promote this holistic approach for vulnerable children and adolescents affected by HIV.
Thank you. Thank you very much, Corinne. Can you confirm that you can hear me?
Yes, loud and clear.
Thank you. Thank you so much. And thank you to ViiV Healthcare, to you, Corinne, and your colleagues in the Coalition for Children Affected by AIDS. My colleague Alison and Michael Smith from WFP, thank you for laying that background for me. Kofi also from ILO, Michelle Bachman, our all-weather friends from PEPFAR, and also our colleagues from the IATT. The challenge winners, excellent interventions, and the distinguished participants that are here with us. I want to talk about essentially the similar things that my colleague Alison mentioned, but maybe focus on three things that we feel that as UNAIDS and the UN bring to the table in terms of promoting comprehensive access to social protection for children and adolescents. The first is that we generate the strategic information to look at the size of the populations that we are talking about, their characteristics, and also the numbers of those that are affected by HIV and what kind of social protection arrangements can best meet their unique needs. In other words, we collect the excellent evidence that has been presented into a form that is digestible by policymakers. So that was my first point, that we generated the strategic evidence. The second point is that we do our best to adopt approaches that give quantum leaps. As Suki, our director, for our department director, mentioned in our opening remarks, we look at interventions that give quantum leaps in meeting the needs of children, orphans, and vulnerable children. We have in mind some of the approaches that were mentioned by some of the presenters here, looking at social protection CAS plus, looking at the accelerator analysis approaches that combine and use synergies between social protection, cash transfers, and other interventions to give maximum outcomes in the lives of our children and adolescents. So that is my second point, that we promote the adoption of approaches that give quantum leaps in meeting the needs of our children. My third and last point is that we use our large footprint as the UNAIDS Secretariat and joint program, bringing together the expertise of 11 UNAIDS co-sponsors and our global member state platforms. WFP alone, their reach is in billions. So if we combine with UNAIDS, we pretty much have the potential to reach the entire world. So programmatically, what this means is that we take all this information and we package it into a form in which member states and governments can commit to. For example, in the UNAIDS strategy and in the UNAIDS political declaration that is coming up shortly in June. So that is my last point in terms of us, the UN, using our large footprint to improve the welfare of orphans and vulnerable children. So the strategic information that I mentioned is available on the UNAIDS website. The normative guidance on how quantum leaps looks like is also available in our various guidance documents that we produce as the UN, and the UN strategy is almost in place, and the UN meeting on AIDS that will operationalize this strategy is also coming up in June. So those were my 3 points that I wanted to share with you. Thank you so much for this excellent webinar.
Thank you very much, David. I'd like to invite Janet Barry to comment on behalf of the OVC task force. Janet, I know that the OVC task force is heavily involved in advocacy at the global level, to donors, to policymakers. And I'm just wondering, in general, what do you think can best be done at the global level to foster and grow these fantastic innovations and holistic approaches that we've heard about today?
Thanks so much, Karina, and to all of our presenters and our colleagues. And what I would say is really this global community of practice, right? And it's really exciting and inspiring to see the elevation of social protection and social protection given the visibility in terms of its contribution, and really essential contribution to supporting children and families, children and adolescents living with HIV across the HIV cascade, and really promoting resilience. And as I was listening to all of our presenters, and Karina, you kind of asked the question, where do we go from here, right? How do we widen the tent? I think, Karina, you mentioned, and others have mentioned, we've seen several examples of types of evidence, really along an evidence continuum. We know of other models that organizations have implemented, and it's really raising that visibility, right? How do we continue to build evidence? How do we generate support for scaling promising practices? And I think to do that, it is bringing these influencers, as our UNAID colleagues have shared, as our USG colleagues have done, the donors and policymakers and governments along this notion of an integrated, coordinated approach. And that is underscored by evidence. Evidence speaks loudly to policymakers and donors. But we also know that these are practices that can be scaled now, right? We're doing two things in parallel. One is looking for more rigorous models that require more rigorous study, and supporting that while we actually scale up promising practices now. I think identifying the multiple platforms, again, as our UNAIDS colleagues and others have suggested, it's bringing all of the influencers together. What are our platforms for raising visibility, for continuing to really anchor what is now a global paradigm shift around how we achieve viral load suppression and retain viral load suppression and resilience for kids living with HIV, kids and adolescents affected by HIV, and how do we then use our existing platforms to continue to anchor that, bring together our clinical colleagues, bring together our education colleagues, bring together our food and nutrition colleagues, so that all of us are speaking to the importance and the necessity and the value and the benefit of, again, as I'm saying, a holistic, integrated approach. And that can start to be seen in how and what we are funding, and how we are talking and working together to continue to expand our understanding of what works. Is that helpful? Oops, you're muted, Karina.
Thank you. That's great, Janet. Thank you very much. We're honored to have Gretchen Bachman still here with us in the live panel. And Gretchen, I really appreciated your opening remarks and the clarity with which you described the US State Department's investment in this holistic approach for OVCs. I'm just wondering if you'd like to comment having heard about all these 8 innovations, if you'd like to comment in general from the perspective of PEPFAR, ESCAC, and the US Department of State.
Thanks, Corinna. And just want to say I'm really honored to be here. This was so rich, and I really appreciate ViiV's support and the Coalition for Children Affected by AIDS and the OVC Task Force for pulling this together, because this is a real opportunity for me to learn as well about all the things that people are doing out in the field. You know, I was really impressed in the range of speakers and their experiences. You know, from Zvandiri to Cheer Up to Brewin Foundation, that you know, this side of the HIV community is doing so much to ensure that treatment success is happening, because we all know and understand that successful treatment is more than having pills and mouths, right? That's something that one of the physicians I work with, Bob Ferris, always says. He says, you know, it's got to be more than pills and mouths to make it successful. And in hearing everybody, I was reminded of a paper that Lucy Kluver from Oxford came out with a couple of years ago called Cash Plus Care, and how these two sides of the coin are so important to make sure that treatment is successful. And while that paper specifically was written about preventing HIV and promoting safe behaviors among adolescents, the idea of cash plus care has really stuck with me. And I think we saw great examples of that today. I think Zvandiri showed us that we really, especially adolescents, but not only adolescents, need that peer support, that community involvement and acceptance in order for their lives to be meaningful and to want to take their medicine. And then we went to examples in Kenya, in Uganda, Ethiopia with the PMTCT that really showed how household economic strengthening was just so critical for people to be able to stay on their drugs. So just really excellent presentations. You know, it's been said that when we talk about, and I think this gets back to Janet Berry's comments a little bit, of how do we sort of convince policymakers that social protection is important. And I would say, as maybe a voice of just one policymaker, that I really do think that most policymakers do get that social protection, that and more broadly, cash plus care matters. I also think, however, that there's always competition for funding, and that to be able to have the social protection and cash plus care heard, that we have to always have our data ready. And it doesn't, while it's ideal if it's randomized controlled trial data, it doesn't have to be that. It has to be good, clean, rigorous data pre-post if that's what you have, to show that because you included cash plus care in your program, you have likely, even if you can't show direct attribution, better viral load suppression, better adherence to drugs, better accessibility to testing, et cetera, et cetera. I think that's where, as a community, we need to make sure what our talking points are, that we have our data aligned, and that we keep repeating our message over and over, because it always is, you know, there is always competition for funding. We know that drugs are critically important, but we also know that this part of care and treatment is also critically important. So being able to, you know, always be repeating that message with data to policymakers, I think is going to be extremely helpful. So again, thanks for having me today. I look forward, hopefully, to get copies of some of these presentations, and also some of the really great studies that people presented. So thanks, Corinna.
Thank you very much, Gretchen. there is so much more to say, and I'm very glad that many of you have put your questions in the chat box, and that the 8 winners of the Reaching All Children Positive Challenge have been answering via the chat box. I'm afraid we have run out of time for any more live discussion, but I encourage you all to go to the website of the Coalition for Children Affected by AIDS, where all of the 8 innovations are showcased. The evidence that's been presented here is showcased in a lot more detail. You can hear blogs from each of the 8 winners and links directly to their organizations as well. I'd like to invite Kathy Ferrier of ViiV Healthcare Positive Action to give her reflections on what we've been discussing in the live Q&A, and also on the 8 innovations that were presented. Over to you, Kathy.
Thanks, Karina, and thank you so much to everyone that's participated today. That has been incredibly powerful. I think I'd also like to thank all those people that are listening to the webinar out there, because you've provided this opportunity for these great challenge winners to present their work and their evidence, which is just fabulous. And hopefully it will allow a lot of the policymakers and the donors on the call to actually think about how quickly and how fast we can move to scale up, where we know that we have proven effective strategies that have been shared by these 8 winners. So ViiV Healthcare was particularly felt it was particularly important to launch this challenge to address the gaps in the evidence around the important role that a broad holistic intervention is needed. So with social protection for the most vulnerable children and adolescents living with HIV, it makes such a huge difference, and we've seen that in the data, which is really strong. I'm very proud of all the winners and their presentations. I think they've done a fantastic job. And as Karina says, there's a new body of evidence now being created from these organizations, which is available to share with everybody. So, you know, I feel very proud of the work that they've all done. I mean, our hope is that new body of evidence will influence the global policymakers and the global donors to really respond to the huge need for redoubling of efforts with these very vulnerable populations, because obviously we're all acutely aware of the impact of COVID on all of our critical groups that we support. But I think we've heard just the very basic needs, the household economic strengthening, the psychosocial support for young people, the basic nutrition. All of these things are just even more important right now, and we do have proven models. So I think it is time to make sure that wherever we can, we go to scale, we reach more children, and particularly focused on these very, very vulnerable children. So with that, I'd just like to say a big thank you to everyone, and thanks, Karina, and to the coalition. You've been absolutely marvelous and great to work with. So thanks to everybody.
Thank you very much, Kathy. As Luann said in her opening remarks, this is the culmination of several years' work. And I would like to echo Kathy's comments that the 8 winners of the Reaching All Children Positive Action Challenge have shown us what is possible. They've shown us how to harness social protection to improve HIV outcomes in vulnerable children. And they've made for me personally, they've made the invisible architecture behind the holistic approach more visible. And they've also shown the bidirectional benefits of social protection, both for HIV, but many other sustainable development goals. And also the value of different kinds of evidence in helping us all invest in solutions that work. And we're grateful to all of them. So I wish to echo Kathy and thank all of our 8 innovators and congratulate them. And it just remains for me to thank everyone watching and participating, and to give special thanks to our co-sponsors, ViiV, the IATT on HIV-sensitive social protection, the OVC task force, and to let you know, I've put it in the chat, but you can find out more about all of these innovations on the Coalition's website. And thank you all for joining us today.